Yes, thank you for the intro, Maya. And I'm going to be reviewing avascular necrosis and sickle cell disease patients today. Um, and I also have a mock case embedded here. So starting off, to set the scene of, a possible case of a patient with sickle cell disease who's also struggling with avascular necrosis. We have a 32-year-old male with history of hemoglobin SS disease on hydroxyurea, who has a past history of multiple vaso-occlusive crises before. Presenter followed to an orthopedic clinic, complaining of bilateral hip pain, describes it as aching, points to the anterior hip near the groin area. Here's like a potential history of what we could be hearing here. Pain is worse with walking upstairs. It's progressively been worsening over the past months. So there wasn't like a acute moment of injury, but just kind of pain that's been aching and nagging and, gradually getting worse. He states that the right hip is of his primary concern or bother. And so he's been taking ibuprofen with increasing frequency. He's walking around without using any assistive device. And then, something that's important to consider is, what he's doing on the day-to-day. So he does work in reception for a medical office, mostly at a desk. So reviewing, surgical history, he's had a cholecystectomy before, mainly medications for his disease-modifying therapy. He's mainly on hydroxyurea and only takes occasional pain medication, but unfortunately has been taking pain medication more frequently due to this hip pain. For his physical exam, we're going to zoom in on the MSK exam. So on external review of the area, there's no wounds, there's no skin changes, there's no particular swelling. The hip joint is very deep underneath the soft tissue and musculature in that area. So, when the provider is palpating that area, you're not eliciting any tenderness in that area. You do notice that the bilateral hips have painful range of motion and the right one is worse than the left. No really neurovascular deficits in the legs per se. A little bit of, I know actually in presenting this now, I'm realizing there's probably too many orthopedic terms in the strength exam here, but basically just checking all the nerve distributions of the legs, like, push down against my hands, bring your ankles up towards your nose. And you notice that when the patient kind of bends their hip upwards, which is abbreviated here as iliopsoas or IP, they do have some pain. And so that limits the strength in those areas. But primarily, the most notable thing probably here is that when the provider is, having the patient kind of move the hip in and out, there's a lot of pain with internal and external rotation of the right hip. So you're just noting, it seems like, maybe something that's deeper inside, or, something that's maybe a pathology within the hip joint. So when we talk about AVN or avascular necrosis, it's also called osteonecrosis, aseptic necrosis, atraumatic necrosis, ischemic necrosis. So all descriptions of basically this blood flow issue leading to ischemia, and which is damage specifically in this case to the bone vasculature, the bone marrow cells. And that's due for sickle cell patients due to the capillaries being occluded by sickled erythrocytes. And collateral circulation is inadequate, basically meaning that, there's no flow, or there's inadequate flow from other vasculature nearby to bring the blood flow needed to that bone. And so those bone cells are necrosing in that area. Similar to AVN is the pathology of like bony infarcts, which tend to be medullary bone lesions. So talking about like the center of the bone having some tissue damage there. Bony infarcts often, though, are asymptomatic findings that are noted on radiographs or x-rays, sometimes incidentally found. They can be described as classically smoke up the chimney, or like a darker white portion that kind of moves up, that looks characteristically like the wavy lines of, what you can imagine as smoke moving up a chimney. I've seen them in my prior orthopedic practice on like a knee x-ray in the proximal tibia or in the distal femur. So, maybe a radiograph was done for knee pain, but then kind of noticing there's something else unusual here. Of note, AVN is associated with numerous conditions. So plenty of other non-traumatic cases. Patients who have lupus can suffer from this, people with heavy alcohol use, people who are on steroids, it can be a side effect there. People can get avascular necrosis after trauma. So a fracture can disrupt the blood flow. And even after maybe a procedure is done to line up the bone in the correct space, the blood flow disruption can be enough for for avascular necrosis or osteonecrosis to develop in a certain area. 70 to 80% of patients have suffer from bilateral AVN in the non-traumatic cases. So that's kind of the population that we are going to be focusing on here. Similar to some of the things you might have noticed in our patient history, patients usually present with pain with weight bearing, or say that motion induces their pain. They might describe it as, again, worse with going upstairs or incline. 2/3 will also have pain at rest. And then in later stages with patients with AVN, they might complain of stiffness, not being able to move the joint through their full range of motion, like it's hard for me to move it. And they might complain of like, I'm limping, it's so bad. I bolded here the most common locations for AVN, which are the hips and the shoulders, but also can be in knees and ankles. The physical exam is often nonspecific. So those findings that we saw in the MSK exam could be AVN, but it also could be arthritis of the joint or, other various diagnoses. Reported prevalence of femoral head AVN in patients with sickle cell disease ranges from 10 to 50%. I know that's a pretty big range, but just added this to kind of demonstrate that it can be pretty common. Maybe half of our sickle cell patients might be suffering with this, and some might not be symptomatic, and then some might be suffering from a lot of symptoms. If you have severe sickle cell disease, you have a higher incidence of AVN. And then as the process progresses, it can progress over months, it can progress over years. Ultimately, the risk is that the bone in that area might also fail. And, there might be some joint collapse, there might be, bone issues nearby due to the structure failing due to this lack of blood flow. So when this is suspected, first we'll talk about the workup here. So we'll start with a radiograph or ordering an x-ray, and one view doesn't do very much. So we're really looking for 2 views. So we're kind of most of my images here are related to the hip, since that's one of our most common areas for AVN. So we'll have an AP view, so the front to back, anterior to posterior view, and then the lateral view of the hip. But of note, you can have a negative hip x-ray and still have AVN. So really MRI without contrast is our gold standard exam. Bone scans, unfortunately, do have a high rate of false negatives, especially if it's early AVN. But it can be used in select cases when other cross-sectional imaging is contraindicated. So here on the right, just want to have kind of a side-by-side view of, these are AP views of the hip, AP radiographs or x-rays of the hip. So the top, that, the pictures labeled normal femoral head, we see this like round femoral head that almost looks like, you could say like an ice cream cone ball, versus the one on the bottom. I see when I, kind of trace along the outline of the femoral head here, it kind of looks patchy, fuzzy, not really round anymore, a little bit misshapen. There's some lucencies, so some extra like darkening here with some patchiness nearby. And again, this femoral head is seated within, the part of the pelvic bone here called the acetabulum. And it looks a little bit different. If I was to see arthritis, I might see that the acetabulum, or the pelvic bone part, looked a little bit different, but you can definitely see the femoral head kind of collapsed a little bit in the hip bone socket. And then one thing on the right, in the rightmost photo, is a crescent sign can be also noted on x-rays. So what the arrows are trying to point out here is in the femoral head, below the edge of the bone, there's this darkened kind of crevice path. I hope you can see that the curvature looks like a crescent, and that can be indicative of the infarcted bone in that area. So here's some MRI slices you might see for a patient with AVN. So the sagittal plane is kind of this horizontal view, and then the coronal plane is this like vertical slice view. So these are again of the hip and of the pelvis. And if you go to this center picture, you can see here the right side again has this round femoral head. I'm not sure if you can see my cursor or not, but I'm trying to trace it if you can see. And then the left hip here has where the edge of the bone that you might see, a fully white round circular edge, there's this darkened area that has kind of this like collapse, or I want to say like eating away of the roundness of that hip joint shape. And then similarly over here to the rightmost picture, again, the right side, I tried to pick some images, some slices where the right side or one side looked different than the other to kind of compare what normal looks like. So the right side here looks different than this left side that has this kind of darkening and collapse of the left hip joint. And the darkening on the MRI can also be seen in this sagittal view on the leftmost side as well. So back to our case, at the time of the first visit, our patient was given orders to get an x-ray. It showed some mild hip AVN. And of course, it might have been negative, but that wouldn't mean that he doesn't have AVN there. But, luckily we were able to see it with our first images. And then the provider felt that, as this patient is young and doesn't work in a terribly active setting, the discussion was focusing on tactics to improve their comfort and preserve their function, and preserve the joint and delay surgery as long as possible. And we'll get into the surgical treatments in a minute here, but basically preserving the native joint as long as possible is to goals of because some of these prostheses have been shown to last for a certain number of years. And so if you're a younger patient, and unfortunately our sickle cell patients will be younger patients who are getting, potentially hip replacements. But the hardware or the study of that surgery is often, followed for a certain number of years. And if that is done earlier, it might limit the future treatment options if pain has continued, or if a hip revision is needed. It might just mean that they're going to be getting more and more surgery. So definitely trying to preserve their natural anatomy and work on comfort and conservative treatment if it's possible. So they're advised to continue their NSAIDs at this time, their kidney function was adequate enough or appropriate enough that they could tolerate that. They recommended to switch to Mobic daily due to side effect profile with fewer reports of GI harm, since we knew that unfortunately this patient was needing it maybe this Mobic dose every day. A PT prescription was given so they could work on strengthening areas that might offload pressure from that joint. They recommended to say, if you're going for a longer distance, try to use a crutch so that you're kind of offloading, especially that right side that's giving him a lot of pain, and, giving some extra assistance there. And then after, patient advised he wanted to try out other treatment options because he was already on an NSAID and was feeling like his pain was still not controlled. So the provider recommended starting a bisphosphonate, and they talked about how that could possibly cause a risk factor of osteonecrosis of the jaw. And we'll get more into bisphosphonates in a couple slides. So again, treatment of non-traumatic AVN. So, in this case and in sickle cell patients, they have non-traumatic AVN. The treatment is controversial because we have limited literature, and then treatment practices can vary regionally and between institutions. Again, as I already said, the goals are to preserve our native joint as long as possible. And then, unfortunately, the mainstay of treatment is surgery. And then we could talk about joint preserving procedures, if possible, versus joint replacements. And then the factors that are at play when deciding on what treatment would be best for our patients, or, which treatment to offer at, particular times, considering their age, how much their quality of life and function and occupation is affected by their pain and their symptoms, and, their activity level in general. So for supportive care, in the femur in particular, and again, a lot of as it's one of the more common locations, I think a lot of the literature also is most strong in the hip. So small medial femoral lesions are the best prognosis. So, this is something that your orthopedic specialist might be concerned about, but for you to know as well. Trying to manage their sickle cell disease as a whole, considering physical therapy, assistive devices, NSAIDs to reduce the inflammation and pain, short-term opioids, or, occasional PRN opioids for pain flares while planning the definitive management. Observational data has shown in one study that asymptomatic lesions that took up less than 15% of the femoral head may resolve without surgery. So again, I guess, the percentage of the area affected, how big is that infarct, is also really, potentially showing how symptomatic the patient is, and how well they might do with certain treatments. Unfortunately, even if a patient doesn't have strong symptoms but do have a large lesion or a large area affected, like over 30% of the femoral head, they do recommend to manage conservatively, but likely that patient would eventually need a joint replacement. So again, just trying to figure out the timing of when that surgery should be. So our patient followed up again at 3 months and then again at 6 months, still complaining of pain, despite the conservative measures that were initiated. So they proceeded to get an MRI, and it did show mild to moderate AVN, but without femoral head collapse. And that was important because they want to consider a core decompression for him, which we'll describe in a minute. But that would be important to not have complete femoral head collapse with that procedure. So patient was agreeable to that treatment. So joint preserving procedures. So again, not replacing the joint, but doing a procedure to hopefully preserve the joint that they have, usually is for younger patients without joint collapse. Asymptomatic patients with a medium-sized lesion, 15 to 30% of the femoral head to stop progression of further AVN in that area. So a core decompression is minimally invasive, still invasive in that there is a small skin incision, but basically the technique is drilling a tract into the bone to create a path for new blood vessels. And sometimes they might choose a smaller diameter drill and drill multiple times. And that technique is associated with a reduced risk of perioperative fractures. The theory of this surgery is that the process of the cell necrosis in this area creates swelling, inflammation, and that this procedure can decompress some of that pressure buildup. Some core decompressions are done with a bone graft or stem cell matrix added into the tract to basically bring a bone graft could bring structural support to that area that, you know, has a risk of collapse, or also new cells that could, you know, be helpful for you know, rebuilding healthy cells. And then in a systemic review of 10 studies with 280 hips treated, all 10 studies reported improvement in patient reported outcomes with cell therapy compared to controls. So that was a hopeful thought, as you know, using these adjunctive therapies in the area along with the decompression. I'm going to be brief on this slide. I'm not going to go through everything, but of course there are several pre-op and peri-op considerations for sickle cell disease patients. We'll definitely be considering, you know, this is an elective procedure. We're not expecting very much blood loss because it is a small incision, relatively minimally invasive, but still really important to, you know, note that his hemoglobin was 8.2. And so he was transfused 2 units with a simple transfusion before surgery, so that he could be well optimized for preventing perioperative complications. They tried to do his surgery earlier in the day to reduce NPO time, because of course dehydration can be a risk factor for crisis. And then, you know, things like incentive spirometry to prevent acute chest syndrome risk. So for our patient, minimally invasive, did not have excessive blood loss. They involved the acute pain service to help control his pain. There were no complications. At 6 weeks, he did have reported improvement in pain control. That 6-week mark is, I would say, pretty common in like orthopedic healing times. He did physical therapy and then advised that, you know, he should continue to follow up if, you know, symptoms, or, you know, depending on his symptoms, and just knowing that likely additional treatments might be indicated in the future. So next, I want to touch upon joint replacements. So when we talk about joint replacements, we can talk about a total joint replacement, or a hip hemiarthroplasty, a half a hip replacement. And here we're removing the necrotic bone and replacing it with a metal prosthesis. This is for patients who have advanced collapse in a certain joint. And again, there are certain perioperative, this would be a little bit, you know, a heavier perioperative load as far as preventing complications, as it is a bigger surgery with bigger blood loss. But a fact that I found that I felt was pretty important to include is that total hip arthroplasty, or, you know, a hip replacement in patients with sickle cell disease had comparable results to patients with just osteoarthritis or arthritis of the area. And then, you know, the 10-year implant survival. So again, talking about like how long can this hardware support that area before it potentially could get loosened or unseated from the bone in that area, which is an unfortunate complication, was 98.9%. So very high for not having loosening in 10 years. So that was very hopeful. Yeah. Over here on the right, I have probably too detailed of a picture here, but kind of showing you the length of an incision that they might have, and then kind of, through a hip replacement. If it's a half a hip replacement, they're removing the femoral head and neck, and putting in this metal implant down into the femoral canal, or the proximal femur. And then if it's a full hip replacement, the cup or the acetabulum will also be resurfaced. And so that way you see in picture D here, that there's also that cup that's actually in the hip bone. These are, some pre to post x-rays. Starting on the left side of your screen, you see that the round ball of the femoral head is again collapsed, and there's some darkened lines that are through the area that should not be there, shown even more dramatically in the middle photo. And then all the way to the right, this is an x-ray of post total hip replacement, where there's the femoral component and the acetabular component, the pelvis bone component, that have both been replaced. And you might tell that this procedure might have been a little bit more challenging, in that you see that there's this screw. I would say in most very straightforward hip replacements, you would not see any screws there. So maybe there was a little bit of extra assistance needed because of this patient's bony infarcts, that they really needed a little bit of extra hardware to seat the implant well in the pre-existing bone. These are kind of what the components might look like. And again, x-rays, this is a front view, front to back view of the pelvis, where the right hip is the native joint, and then the left hip, this is what a x-ray of after a total hip replacement might look like. Talking about complications, in general, it's considered a successful surgery. You can have risk of intraoperative fracture of the nearby bone, unfortunately. There's a risk of neurovascular injury to the neurovascular structures around that area. And it's possible, if it's not sized correctly, that the patient might notice that one leg might be a little bit different than the other. And then, every surgery does have a risk of blood clots, DVT-PE. Orthopedic surgeries have higher risk of blood clots. There's plenty of reasons that, our sickle cell patients might have even more risks of that. Surgical site infections, prosthetic joint infections, dislocations. So every time we disrupt the natural anatomy of an area, it has a higher rate of dislocating than a native joint does. If you hear that someone complains of a pop or a clunk, or I felt a pop and then I couldn't put any weight on my leg, that would definitely be a reason to say straight to the ER for x-rays. And then osteolysis. So bone nearby being reabsorbed as a biologic response to particulate debris of, needing to manipulate that area. And it can be asymptomatic until the whole implant loosens, which can be quite challenging and would definitely be an indication for revising or needing another surgery there. Here are some other interventions that are, possibly within the realm for patients being treated with avascular necrosis. I included them all in the same slide because there is just limited data, and these can be used, again, sometimes varying different institutions, varying regionally, but there's not strong proven benefit for these therapies. So I would be interested to kind of open up the discussion to hear if people have had experience with patients with AVN in their various regions and institutions, if you're seeing these being used, but they all have their kind of different mechanisms. So bisphosphonates, they're slowing the resorption of necrotic bone. Statins sometimes can be used to try to prevent AVN by, or prevent progression of AVN by reducing differentiation of marrow cells into fat cells and also decreasing pressure there. If we vasodilate the vasculature in an area, it's thought to decrease the pressure again within the bone and increase blood flow to the area. Shockwave therapy, bone healing through stimulation and neovascularization. So again, these are kind of like going at stimulating new bone growth versus reducing the bone breakdown, which is what I'm saying, the resorption. And I honestly feel like I haven't, when I look at this whole list, hyperbaric oxygen, like, okay, if we oxygenate more, can we improve bony healing in an area? I haven't seen any of these consistently used at Hopkins, so I'd be interested if anyone has, any experience from their areas as well. And yep, here are my sources, and would love to open up the floor and hear any feedback. Thank you for the opportunity to share.
Thank you so much. That was so informative. I always say if I learned one thing from a presentation, it's been a success, and I've learned definitely more than one thing. So thank you so much on the thoroughness of that presentation. And I always wonder too, from a hyperbaric standpoint, like, would there be some benefit for sickle cell, even with like sickle cell ulcers, which is a complication? You would think that there would be some, but we don't have the data from that. I have just one question from an orthopedic and an assessment standpoint. So like when I'm trying to rule in or rule out a suspicion for AVN, my typical assessment involves just internal and external rotation of the hip. Is there any other assessment that would be helpful to add in our evaluation to give us more? You're muted too.
That's a good question. I think that range of motion, I always like to do a brief strength exam and, touching both sides, there's no neurovascular deficits. Because of course with hip pain, sometimes we're wondering, is it coming from the back kind of radiating down, and maybe you just have some back pain, or is it really coming from the hip? So I feel like just doing a brief strength and sensation and seeing if there's any numbness tingling would be important. But yeah, there's probably not much you're going to see externally. And yeah, range of motion is important. So I think you're doing the right thing there.
Awesome. Does anybody else have any other questions? I want to make sure we have an opportunity to ask questions, then we'll dive into our case presentation by Ashley.
I have a question. So if you do a X-ray and you don't see anything, do you guys always then do an MRI?
I think it probably depends on the amount of functional deficit and the amount of pain a patient's having. I'd say not always an MRI. I think they'll probably would try treatment first and then have them follow up and consider that.
And insurance kind of sometimes requires that too, because usually I want to do an MRI right afterwards, because obviously we know early stages aren't always detected by X-ray. And a lot of times I get pushback from the insurance that they would need at least 6 weeks of physical therapy, et cetera, for improvements. Perfect. Well, that was, I have so many other questions. I might have to just reach out to you after because of the cord decompression, et cetera, but I want to make sure we have time to present. And if so, I'll ask towards the end as well. But thank you so much. That was really informative and I appreciate everything you're doing and helping our patients as well in a different type of setting. So I'm going to hand it off to Ashley now. Sonia, if you don't mind, or Ashley, do you want to share your screen since you're at your computer? You want Sonia to do it for you and we can dive into your case.
Sonia, do you mind sharing the screen? If you have it handy, it'll just take me a second to find it.
No, I have it. Give me a minute.
Thank you. And so this patient is actually a new patient of mine that I have not met in person, and I'll be meeting him later today. So he's a 48-year-old with hemoglobin SS disease, currently outpatient with worsening anemia, was referred from primary care to see us, but is an established hematology patient of ours. Will eventually be Dr. Landskron's patient, but follows the Dr. Axelrod for primary care, currently on Suboxone 8 milligrams TID that started a couple of months ago. He was previously on MS-Contin 60 BID and MSIR, and that was titrated down and he was transitioned over to Suboxone. You can see his home medications, which include folic acid. He's on Procrit. I will confirm with him, but it looks like he takes about 6,000 units Monday, Wednesday, and Friday, is on some Lokemla for hyperkalemia, and he's got issues with gout, and he status post a steroid taper 2 weeks ago. Not inpatient, so not on any opioids. He does not have a stroke history, but has a history of press. Unclear etiology if it was medication induced, but did have 2 seizures at that time. This was several years ago and had been following with neurology and has been seizure free. And neurology actually was able to wean him off of his Keppra and he's been doing fine. Doesn't have a DVT or PE. He did have an echocardiogram and a right heart cath in April of this year, which did confirm that he had pulmonary hypertension, although you'll see later that his hemoglobin is fairly low. So that is a contributing factor. He does follow with nephrology, and he has renal disease. His last ferritin was 1,500, although that looks like the last one, the only one that's been over about 1,000. And so it's hard to tell because that was like in the middle of an inpatient admission, if that was sort of hyperreactivity and high because of that. Does have a history of depression and does follow with an LCSW and behavioral health and embedded in the primary care clinic. He sees no bipolar or substance use disorder or suspicious opioid use. He is not currently on hydroxyurea. In the past, he was on HU, but felt like he had more crisis, so stopped. But from what I can tell, that was like over 5-6 years ago. Never on chronic transfusion therapies, got a history of an anti-C antibody. His last transfusion was on March 25th of this year, where he got 1 unit inpatient, which sounds like it was during a symptomatic anemia episode. He was seen in primary care. Unfortunately, these vitals were done 2 weeks ago, so it's just giving me a little bit of angina about them, but he was tachycardic to 104, blood pressure 103/54. He was afebrile 98.4 degrees Fahrenheit. His SAT was 85%. It looks like that was probably on room air, and he reports to be on high flow oxygen, although I can't really tell how much oxygen he takes at home. His hemoglobin, it looks like at baseline is 4 to 5. His most recent hemoglobin was 4.7. His white count was 17,000, neutrophils 11.6, MCV 92, and platelets of 295. He has not had, with those labs, didn't have a recent absolute retic count, but looks like they averaged anywhere from like 130 to 260, and he's been on EPO for at least 2 years now. His hemoglobin S from April of 2016 was 83%. His creatinine was 2.9. Looks like his baseline's about 2.4. So this is a jump from when he was seen in primary care 2 weeks ago. Billy was 2.0. No recent urine toxicology screen. His echo, you can see from April, showed severe bilateral enlargement. He had this interarterial septal aneurysm. He is followed by cards here. And then severe pulmonary hypertension with an estimated PA systolic pressure of 86, an atrial pressure of 15, and an EF of 65%. I don't have his education level, but he is on Medicare. Medicare, does get transportation through Medicare. He follows closely with our social worker, has had some issues with social determinants of health related to paying his cable bill, but there is a community health worker that follows him pretty closely. So this patient was referred to me after worsening. It looks like slightly worsening anemia, although maybe it's a little bit of his baseline, but was a little bit more relatively a little bit more symptomatic, although the primary care says, oh, he was asymptomatic, although his oxygen saturation was quite low and he was tachycardic. So, you know, if I was seeing him in the office, you know, 2 weeks ago, I probably would have done a little bit more of a workup. But my question today is really like sort of where to go from here from a disease modifying therapy standpoint, especially since our disease modifying therapy is quite limited these days, even more than what it was.
Awesome. So just to summarize, this is a 48-year-old with hemoglobin SS who's referred to Ashley for worsening anemia. He does have past medical history for chronic kidney disease. So now we're dealing with not only a destruction issue, but now a production issue. Also has history of diabetes, asthma, gout, pulmonary hypertension, iron overload, major depressive disorder, and history of seizures secondary to depressed, which seems controlled. Baseline hemoglobin is 4 to 5, creatinine 2, total bili 2. So the fact is bili is still elevated. A lot of times with the CKD, we sometimes think it might be a production issue, but this is kind of confirming that the sickle cell and CKD more than likely are impacting that. So the questions I wanted to ask to clarify was, what dose of Procrit, and is this being given in dialysis? Because a lot of times I find that they underdose just based on whatever their maximum reimbursement can be.
Yes. Yep, agreed. I have the same experience. So it appears, and I'm going to confirm with him today, that he's getting 6,000 units Monday, Wednesday, and Friday, which is kind of a dialysis dosing. He is not on dialysis. He does this at home, which seems a little cruel to give yourself 3 times a week injections at that dosage. Usually, in my experience, I would give like a larger dose once a week. Seems a little bit more friendly.
And even so, he's only at 18,000 total per week that we could consider if it's not being given in dialysis, because usually the loophole that I find is we'll have our patients stop receiving it in dialysis and just self-administer at home. That the first step could be considering just making sure he's on an effective dose. You mentioned his ferritin being 1,500, but I'd want to check that when he's feeling well and out of the hospital, because they give iron infusions for Procrit just to make sure our patients have the building blocks necessary to produce new hemoglobin. So I'd want to make sure that when is evaluated. And then sometimes from a hydroxyurea standpoint, I know when patients have the perception that it was causing more harm than good, they don't want to restart it, but I still circle back, especially if they've had worsening in their organ function. So I wonder what the onset of the CKD was, because maybe it's something worth revisiting because we don't have Oxbryta anymore. For those on the call, Voxelotor, Pfizer had a voluntary withdrawal worldwide for their product. Just they found that as it stands, the risks outweigh the benefits. So while they are looking in their data, et cetera, this one is no longer available. Otherwise, that would have been a logical addition to consider for him. But I would consider just showing the information for hydroxyurea and say you already have kidney disease. The prognosis once you go into dialysis is much worse compared to pre-dialysis, that we need to do what we can to preserve whatever organ function you have left and try and see would they be open to hydroxyurea again, potentially, and just starting slow as tolerated. Is his, it seems like anemia is more of the issue than pain for him, correct?
Yeah. I mean, it seems like he's done relatively well on Suboxone over the last, couple of months. He hasn't really had any hospitalizations, really doesn't look like he's had a lot of acute painful episodes, although his hemoglobin is so low, he doesn't really have that many circulating sickle cells. So the other sort of piece, right, I agree with you, like increasing the EPO dose. Like I normally would start with people with better kidney function than him at 20,000 a week, right? Like would be a low dose. So I think he definitely needs more than that. The one thing I was considering, at least in the acute phase, was transfusing him to see if that helps bring his hemoglobin up, helps his end organs a little bit. And if he didn't want to do hydroxyurea and EPO, trying chronic transfusion. I mean, it sounds like from our blood bank that we could get enough blood for him. He just has an anti-big C, not a little c antibody. And that may help him feel a little bit better. And I would honestly be interested to see what that looks like from his like cardiopulmonary function, because like they did a right heart cath when his hemoglobin was 5. So I'm like, does he really have pulmonary hypertension? Like he may, right? But he also lives with a hemoglobin of 5. And so would his pulmonary pressures will look a little bit better and take a little bit of strain off his heart. I'd also be interested to see what his renal function looked like with a
Okay.
higher hemoglobin. I don't know. I mean, some of it is, you know, he's 48 years old with sickle cell disease. Some of it may not be completely reversible, but
With diabetes too, so he has
and
multiple
diabetes.
conditions that are impacting that.
Yeah.
I think there's studies on the chronic transfusion therapy for the function or people with albuminuria and trying to evaluate the effectiveness of preserving kidney function. And then with the pulmonary hypertension, there could be benefits to raising the hemoglobin either from a medication standpoint or from chronic transfusions if he's open to that. Is anybody on the call? Does anybody have any other clarifying questions or suggestions on what they would do in a case like this? It's 9:56, so that's why Ashley and I are talking really fast. So, but I want to make sure that everybody has an opportunity to participate if they have any other questions or have seen similar cases like this.
So would you, if you were gonna choose between EPO and hydria or chronic transfusion in this case, what would you choose?
Honestly, I probably would put him, at least now in the acute phase, I'd transfuse him. And then we could talk. I would certainly talk about sort of both options and give him the option, but I think acutely he needs to be transfused because he's symptomatic. And I really hope he's not statting 85% when he rolls through the clinic tomorrow or today. But because that will be a whole nother piece of trying to get him transfused a little bit more rapidly. But I think at least in the acute phase, giving him blood, help his hemoglobin, help his oxygen saturation. And then, you know, if he wanted to try EPO and hydroxyurea, right, I think it's a reasonable option for him. He's never had a stroke before. And if we could optimize his hemoglobin that way. But if he's like absolutely adamant, no hydroxyurea, then I think it's kind of stuck.
And I think this is where we kind of utilize shared decision making because we don't have something saying what is the best. So we kind of have to work with, we talked about social determinants of health earlier, but we need to look at the social determinants of health and things that would potentially pose as a barrier to accessing the monthly transfusions or treatments, or are they capable of self-administering, et cetera. So if it was my patient, I would kind of present the options, but highlight something needs to be done because his body constantly having to work under with low hemoglobin with all these other comorbidities obviously is going to negatively impact. So from this case, it seems like the best options are maxing his dose of Procrit plus or minus hydroxyurea and or chronic transfusions. And in the meantime, since he might be symptomatic, at least from an oxygenation standpoint, do simple transfusions. And hopefully maybe in 2026, we will have even more options that could help raise his hemoglobin. So I'm so sorry for rushing. It seemed like a small group and I wanted to just do introductions so I can learn new people and APPs and whatnot in the community, but I apologize. This resulted in us having to rush towards the end. But Sophia, thank you so much for presenting. It was so thorough and so interesting and I learned a lot from that. So thank you so much. And I love seeing the images because I always try to pretend I know what I'm seeing on the radiographic. So I feel a little more confident, especially with that crescent sign, which is fitting for sickle cell with the crescent shape. And Ashley, thank you so much for your case. I think it's interesting, especially more than half of us are adult providers. We are seeing just increased comorbidities with CKD, et cetera, just from high blood pressure and diet, et cetera, in the United States. So this is an applicable case that we all probably know at least one patient. So the link is in the chat. So if you want to claim your CME credits, that would be great. As a reminder, we're going to be having these echo sessions the first Tuesday of every month from 9 to 10. So if you're ever interested in presenting a didactic or a case presentation, just let us know. And please share with other colleagues who might be interested because it's a great opportunity for us to just continue to expand our knowledge, talk about hot topics, and just learn from each other. So with that, happy Tuesday, everyone. And thank you everybody for participating in this week's Echo, or this month's Echo, I should say.
Can I ask a quick question about the CMEs?
Yeah, of course.
Well, once you click on that link, should it show on your transcript pretty immediately or does it take time?
I'm going to defer to Sonia because I am not sure.
Yes. So once you click on the link, it'll probably take about a week for it to show in your transcript.
Okay. Great.
Yeah. You're welcome.
Thank you, everyone. Have a great week. Talk to you guys soon.